say on behalf of all the ministers and all the delegations that we congratulate the Director General of the WHO, which was he was decorated yesterday with the Prix de Lyon by the President of the Republic, and so we'd like to congratulate the Director General of the WHO. And we would also like to greet the Minister of Comoros. There has been a cabinet reshuffle in the country. However, the minister has retained the function of Minister of Health, and we congratulate you therefore. We are now going to proceed with the analysis of agenda item 13, which is ensuring sustainable financing for universal health coverage in Africa, and it is document AFR RC 6810, and I'd like to give the floor to Dr. Prosper Tumisine, the Acting Director of the Health Systems and Services, to introduce this document.
Thank you very much, Chairperson, the Director General of WHO, Honorable Ministers, ladies and gentlemen. On behalf of the Secretariat, I have the privilege to introduce document AFR/RC68/10 entitled Ensuring Sustainable Financing for Universal Health Coverage in Africa in the midst of changing global and local economic factors. The purpose of this document is to guide the Member States on evidence-based actions for ensuring sustainable financing given the regional and global macroeconomic context. We'll first of all provide the context. The 58th World Health Assembly adopted Resolution 58.33 on sustainable health financing using universal coverage and social health insurance, and urged adoption of sustainable financing mechanisms, including prepayment schemes, to attain UHC. This commitment was further affirmed with the adoption by the United Nations General Assembly of the Sustainable Development Goals in 2015. The World Health Report 2010 highlighted sustainable financing as a critical pathway to ensuring UHC and protect households from financial hardship when accessing health care. This paper provides further guidance to the African region member states on implementation of sustainable financing to achieving UHC. As you may recall, last year, the 67th session of the Regional Committee adopted the framework of actions for strengthening health systems for universal health coverage and the Sustainable Development Goals in Africa. It provides a menu of options for countries to consider, including health financing as they improve their systems and services to facilitate achievement of UHC and other Sustainable Development Goal targets. The key challenges and issues include total health expenditure in the region, which has grown at 6.83% per annum, though not still near other regions. Some member states, including Gabon, Rwanda, and Ghana, among others, have made commendable progress in financing reforms towards UHC. However, average government spending in the region as a proportion of total health expenditure averaged 9.9% in 2015, still less than the 15% Abuja target. The region still has high out-of-pocket expenditure, with currently approximately 34% average out-of-pocket expenditure as proportion of total health expenditure. Therefore, the African region has growing rates of catastrophic spending, and with recent estimates that show that 11.4% of the region's population, about 108 million people, have been impoverished by spending on health. The paper therefore makes a few recommendations and issues that we invite the regional committee to look at. It recommends that member states should establish mechanisms for domestic resource mobilization, including mandatory prepayment mechanisms, general budget funding, and innovative health-linked taxes. It also recommends that member states should improve efficient utilization and gain value for resources invested money with effective public financial management and strategic procurement of goods and services. It also recommends that member states improve their planning for transition from external financing, for example, from the Global Health Initiatives, Gavi, Global Fund, and others. That member states also establish essential packages of health services that cover the essential needs and are funded through evidence-informed policies that encourage sustainability. It also urges the Secretariat to support capacity building for member states on health financing reform and defining other UHC processes through peer exchanges and learning. The Secretariat also is urged to build evidence on what works for sustainable financing for health systems and to monitor progress in sustainable financing for universal health coverage. While we invite the member states to look at this, we ask that the regional committee also considers the resolution that had been passed last year, AF/RC 67/10 of the 67th Regional Committee. Honorable Ministers, this document is submitted to the Regional Committee for your review and adoption. Thank you very much.
Thank you very much, Dr. Tumisimi. I would like to know if delegates have comments or observations to make with regard to this document. I give the floor to Zambia.
Thank you, Mr. Chairperson, for giving Zambia the opportunity to contribute to this agenda item. We recognize that the attainment of UHC is a smart investment for any country, and we're making strides to ensure that the entire population has access to quality health care without being exposed to catastrophic health expenditure. Chairperson, the current situation in Zambia shows that while access to primary health care remains free of financial cost to all Zambians, statistics indicate that about 5.7% of households suffered catastrophic health expenditure in the year 2015. In absolute terms, government expenditure on health has increased over the recent years, but the percentage of government health expenditure to total health expenditure declined slightly over the past 2 years. Out-of-pocket expenditure as a proportion to total health expenditure, on the other hand, remains stable at around 12.6% in Zambia. Further, external donor funding has remained a very important source of financing for healthcare, and it accounts for slightly below 40% of total health expenditure and is mainly tied to specific vertical disease programs. One important achievement towards UHC in Zambia has been the enactment of the National Health Insurance Act, which was enacted in April 2018. It is aimed at providing health insurance cover to all Zambians. As a domestic funding modality, the scheme will supplement the traditional tax-based donor tax-based and donor funding mechanisms in the health sector by providing the much-needed additional resources. Additionally, Zambia has institutionalized the national health accounts in order to track resources and monitor efficiencies within the system in a timely manner. Chairperson, UHC goes hand in hand with quality health care services across the continuum of care, from health promotion, disease prevention, curative services, rehabilitation and palliation. There is need, therefore, to address the human resources for health, infrastructure and availability of medical equipment and supplies. We call upon all stakeholders to continue supporting our efforts and implore Secretariat to facilitate learning and exchange of good practices among member states. With this, Zambia supports the adoption of the actions proposed in the report. I thank you.
Je vous remercie.
Thank you very much. I'd like to give the floor to Ethiopia.
Thank you, Mr. Chair. Ethiopia notes a report by the Secretariat regarding ensuring sustainable financing for universal health coverage in Africa in the midst of changing global and local economic factors. Ethiopia recognizes the issue and challenges identified in the report, particularly inadequate spending of health, high out-pocket expenditure, inadequate coverage by prepayment scheme, weak information system, and evidence for health financing. Ethiopia is aggressively working to expand the community-based health insurance to increase domestic financing for health and to decrease the out-pocket expenditure. The public financing, including per capita allocation for health, is also increasing from year to year. To this end, the government of Ethiopia adopts the report, actions in the report, and commit to act accordingly. And we would like to urge the member state, WHO, and partners adopt the proposed action point in the report and support the countries on the implementation process. I thank you.
Thank you. We give the floor to Niger. Thank you very much, Mr. Chairperson. Niger would like to thank and congratulate the Secretariat for having prepared this document on the issues of funding for health and presenting it at this important regional meeting. The construction of an architecture for sustainable financing for universal health coverage is important in Africa, especially bearing in mind current economic situations which are prevalent both in the north and the southern countries of the continent. So Niger has already started to implement some of these measures, and I would like to mention some of them. First of all, to identify domestic resources to finance health through carrying out of a study on different sources of funding and possibility of social protection. I'd also like to mention that with regard to mobilization of domestic resources, we are focusing on health, and we have adopted a law in 2018 which applies new taxes on VAT as well as interurban transport that is in the country, that is being developed in the country. So with the support of partners, our ministry has created a champions network for mobilizing funds for health. And on the eve of the adoption of the laws, it organized a awareness campaign with all parliamentarians. The WHO also helped us to create our national accounts for health. And to conclude, I believe that our countries will only be able to ensure universal health coverage through the mobilization of resources, and this obviously requires the courageous engagement of all our decision makers. And many of these decisions are actually contained in this document, which we support. Thank you. Thank you very much. I give the floor to Kenya.
Yeah, thank you, Mr. Chairperson. The Kenya delegation takes note of the report from the Secretariat on ensuring sustainable financing for universal health coverage in Africa and welcomes the proposed actions for member states, WHO, and its partners. Mr. Chairperson, in Kenya we are very clear that progressive increase in predictable and sustainable domestic financing is key to the achievement of universal health coverage. This will guarantee that countries avoid disruptions in service delivery, ensure timely payment of salaries, invest in the required infrastructure, and also provide a credible basis for contracting with the different service providers within the health sector. We do know that with the decline in donor support coupled with transition arrangements from financing agreements such as Gavi, Kenya has continued to increase budgetary resources to health over the last decade. And I can confirm that since 2013 to date, the budgetary allocation to the Ministry of Health has increased threefold. And in the same vein, allocation to the county governments to the health sector has also increased by about 30%, from about 13% in 2013 to about 25% in the budget year 2016-17. Additionally, Mr. Chairperson, through subsidies and increased contribution to our National Health Insurance Fund, the National Health Insurance Fund has expanded the benefits to its members, and also we will continue to encourage greater private sector investment. And we are also currently considering expanding our tax base through a new tax regime that includes Robin Hood taxes to be able to finance the healthcare. And this is within the context of a presidential agenda on universal health coverage that is the defining legacy for the President of the Republic of Kenya. With regard to the report, the Kenyan delegation requests the Secretariat to sharpen the focus of the document by including specific examples from the African region, which can be replicated by member states in view of a unique context as a region. We'd also like to propose the inclusion of the critical role that is played by the Ministry of Finance and also by the legislature in increasing investments in the health sector. Also, in addition to creating the need to create an enabling environment for private sector to partner with governments for enhanced service delivery. Mr. Chairperson, the Kenyan delegation takes note of the report and supports adoption of the proposed actions. I thank you, Mr. Chair.
Thank you. I give the floor to Cote d'Ivoire, and then Tanzania can take the floor after that. Thank you very much, Mr. Chairperson. Cote d'Ivoire would like to thank the Secretariat for having introduced this item on the agenda, and we would like to acknowledge the fact that population health is an essential component of sustainable development, and it is inseparable from all the other objectives on the social and economic front. We recognize that Sustainable Development Goal 3 requires additional funding in order to strengthen the health system, as well as to ensure universal health coverage on a sustainable way. The Ivory Coast, through its Ministry of Health, would like to reaffirm its engagement to ensure sustainable financing for universal health coverage in Cote d'Ivoire, and we're carrying out various activities such as, for example, strengthening our internal financial resources for the health sector through advocacy and dialogue regarding the budget. And we're hoping this way to ensure that the health budget increases from 8 to 10% of the general state budget. We would like to focus more on health priorities, have better management of the control and use of the resources, ensure better auditing of the resources, which will allow Cote d'Ivoire to increase its resources and optimize such resources, creating a favorable context for progress and ensuring universal health coverage this way. In this way, we'll be able to improve population health. We take note of the report and we support the adoption thereof. Thank you very much. Tanzania, you have the floor.
Thank you, Mr. Chairperson. The Tanzanian delegation is appreciative of the opportunity to contribute to the agenda item on the table on ensuring sustainable financing for universal health coverage in Africa. in the midst of challenging global and local economic factors. To this, the delegation commends the Secretariat for including this important agenda item and for the report, which has provided a technical review summary on including issues, challenges, and a proposal for consideration. Since independence, the government of Tanzania has implemented different health reforms towards ensuring sustainable financing for universal health coverage, which reflect government's commitment towards attainment of sustainable development goals and the plans towards a middle-income country. Some of the ongoing activities, Mr. Chairman, are to do with the investment in health system strengthening, with endorsement of the national primary health care, which is still a critical component of our effort in ensuring universal health coverage. Implementation of the primary health care has resulted in substantial increase in number of health facilities, especially in rural areas, and this has remarkably improved access to quality services. Efforts are ongoing to improve the quality of health services provided, especially in primary health care facilities, building on a people-centered approach where direct financing for health is implemented to improve quality of health services provided. Also, to ensure sustainable quality of health services to all individuals, the government has instituted different mechanisms for citizens to join national health insurance with target to cover at least 70% of the population by the year 2020. Mr. Chairperson, we take note of the listed challenges and issues raised in the report, especially the declining economic performance among member states, which is a broad issue of development affecting other sectors beyond health. We support the proposal to improve efficiency in health spending by governments as stipulated in the Abuja Declaration. Implementation will need to be country contextualized individually. Therefore, we urge WHO to continue pursuing and facilitating increased manufacturing capacity of essential drugs, vaccines, and other health commodities in our region to reduce the dependence in the continent. This will ultimately contribute to self-reliance. Tanzania takes note on the proposed actions to be adapted as appropriate according to national context. We thank you.
Thank you. Seychelles has the floor. DRC will follow.
Thank you very much, Mr. Chairman. Seychelles joins all the other delegations in expressing appreciation to our hosts for the wonderful arrangements, and we also welcome this report which has been proposed. Universal health coverage is obviously one of the cornerstones of the Sustainable Development Goals. Seychelles has put a lot of emphasis on the implementation of universal health coverage, and we have implemented a free at the point of access universal coverage system since the early 1980s. A recent World Bank report has shown that our health system delivers efficient results both in terms of outcomes and relative to the inputs. The health spending is currently approximately 13% of our total government budget and just below 4% of GDP. What this tells us, if we benchmark ourselves against for example, OECD countries, is that we can increase as a percentage of the economy the amount that is invested in healthcare. And we look forward through the initiatives that we are developing with other African countries at ways in which we can mobilize more resources from our national economies to be invested in the healthcare systems. This is particularly a matter of concern for small island developing states in the African region, where we are seeing many drivers that are increasing costs exponentially. One of these drivers of increasing costs is, of course, the human resources element, where small island developing states are often having to recruit also from outside of their countries to be able to ensure that they have the appropriate human resources for their health systems. And the cost of increasing specialization means that the overall cost of delivering universal health care will continue to increase. We also have the increase in the disease burden, particularly non-communicable diseases in small and developing states, and we must properly support particularly African small island developing states to be able to properly project the expected increase in spending and looking at mechanisms that can facilitate more domestic resource mobilization. We can note as well, therefore, the importance of proper data collection, and this is an area that we hope we can work with WHO, AFRO, to continue to improve the capacity of African small island developing states. We also note the initiative of the Director General, in relation to supporting small island developing states, in particular to address the burden of climate change, which obviously has a great bearing on the cost of delivering healthcare in our countries. In Seychelles, we continue to implement various policies to improve the financing in the health sector, which include high taxes on alcohol and tobacco. As of January 2019, we will be implementing a sugar tax, which will simultaneously help us to address the issue of obesity and the rising NCDs, while also raising additional resources that we are working to ensure will be invested directly into the health system. We are also looking at mobilizing additional national resources through some form of national insurance mechanism to complement the existing national system, which allows free access to all citizens at the point of use, but keeping in mind the expected growth in the cost of universal healthcare in our countries, and therefore the expected increase of the burden per capita, keeping in mind our very small population and tax base. We welcome the report, and we look forward to working with WHO on more detailed issues concerning the support of financing of universal health coverage, particularly in the context of African small island developing states. Thank you, Mr. Chairman.
Je vous remercie.
Thank you. DRC has the floor. Will be followed by Uganda. Thank you, Chairperson. In spite of an increase in relative values, the DRC's health budget has stayed in the range of 7% from 2008, and it was 14% versus the 39% from donors, etc. In spite of the increase in the budget to health, the public health expenditure compared to total expenditure has only increased slightly from 5% in 2008 to 6% in 2016. However, there continues to be inequality in terms of funding at different levels of the health system. In 2016, the central level had 33% of the funds, which went mainly to staff remuneration. Conversely, at the province level, it was 22% to support the health zones, but at operational level, it was 65% of the funds for curative, preventive, and promotional care, as well as readaptation. Medicines and hospital expenses remain the main sources of the heavy expenditure on the households, up to 58% for medicines and 18% for consultations. There is a very low level of coverage in terms of health insurance. This is only 2% of the population. This exposes most households to very heavy expenditure, which impoverishes them. There is a high dependency on external funding to deal with large-scale interventions against HIV, AIDS, malaria, tuberculosis, and various endemic diseases and outbreaks. However, significant progress has been made from the local funding to the tune of $36 million. 66 general and reference hospitals were built and rehabilitated, as well as 300 health centers. There was also the virtual basket front between all the technical and financial partners and the government to reduce the fragmenting of funding given to the provinces. Today, there is a strong commitment on the part of the state to tackle outbreaks, especially Ebola, cholera, and gradual application of the strategic procurement strategy, as well as the establishment of a general inspectorate of health. We do have a few challenges, though. We have the need to increase the total budget of the state to reach 10% in the next few years. to improve execution of this budget to the tune of 80% and to sustain the development of risk-sharing mechanisms for diseases so as to reduce the financial barriers to care and impoverishment on account of health. A few prospects that we have that we wish to contribute to this document, increasing available funds by improving the system of collecting and administering revenue so as to reduce tax fraud and mismanagement, increase the proportion of public resources for health by giving a certain percentage of taxes on harmful substances and those that destroy the environment, optimize the resources for the sector by ensuring that the resources are allocated to all levels, simplify and harmonize procedures for management in order to ensure better tracking and accountability and a better ability to forecast expenditure. Respect state commitments vis-à-vis technical and financial partners in terms of financial resources for provinces and decentralized units. Improve the execution of feedback, retrocession to the tune of 30% of the national revenue. And to reduce financial barriers to access to quality health services. And for this, to develop a multi-sectoral approach through innovative mechanisms for sharing risk relating to disease. What are the assets that the country proposes to contribute to funding so as to achieve universal health coverage? It is to emphasize mobilization, pooling, and efficient allocation of financial resources, adoption of lump sums for treatment, for payment for care, which will provide some protection and ensure progress in UHC. 3 is the state's commitment through the Global Financing Facility for the SMRI strategy. Better alignment of resources to national priorities. And on the part of the government, it is the highly meaningful decision to ensure that all projects take the form of program budgets by putting in place a comprehensive multi-year budgetary framework. And finally, since 2014, a partnership charter was signed with all partners involved in health for better commitment of partners and harmonization of actions along national priorities. On this, chairperson, the country supports this document, which will enable us to achieve universal health coverage. Thank you. Thank you. Uganda has the floor, to be followed by Central African Republic.
Thank you, Chairman. Uganda joined the rest of the other countries to commend the Regional Director and the Secretariat for the report. Reorienting health programming to the universal health coverage agenda requires new strategies and methods on how to manage the financial burden to individuals, the health systems through paying attention to government budgets, aid flow, prepayment mechanisms, service providing institutions, and their regulation. Even with the current financial levels of our countries, effective strategic purchasing is still inadequate, as we were told yesterday in the side event. We have a lot which we can buy with the current resources if only we can be efficient purchasers. However, increasing per capita spending alone will not be enough. We must spend on the right high-impact intervention targeting those most in need. Introduction and expansion of the prepaid schemes for health is quite urgent for most of our countries if we have to reduce the out-of-pocket expenditure and also to driving most of our population to poverty. In Uganda, we are in advanced stages of introducing the national scheme for insurance and we acknowledge the support we have received from WHO and other partners. In addition, the country is exploring various innovation options to raise hypothecated financing for health, including tapping into the third-party insurance for motor vehicles. In addition, advocacy for health in all policies and ensuring that investment in other sectors that have influence on population health are done optimally can take us a long way towards realizing universal health coverage within the resources constraints we face. USC is a political issue, and leadership by the heads of state, cabinet, and parliamentarians is critical to increase resourcing for USC. Uganda adopts the recommendation actions in the report. I thank you, Chairman.
Je vous remercie.
Thank you. Central African Republic has the floor, to be followed by Guinea. Thank you, Chairperson. I would like to congratulate the Secretariat for this important document. Of all the points that we have discussed at this RSA, financing has been the backbone. If there is only one point on which we need to make progress by next year, it should be on financing. What I would like to say is that, well, I'm young as a minister, but since I was appointed to this position, I get the impression that the WHO is absent from all matters related to finance, and yet that is the bottom line, really. I don't know precisely what activity the WHO is carrying out in support of the countries on this matter, both technically and politically. Apart from the funding that they mobilize for themselves and they support us with. But I'm saying this because maybe countries are not all at the same level in terms of the need for support from the WHO. But from where I stand, I see that the WHO is important, normatively speaking, and also politically. In other words, top-level advocacy can help the ministries of health in their dialogue with the Ministry of Finance, because we often feel that because we have the Minister of Health here, he is going to be able to apply it, but he cannot do it alone in his country. But where the money is concerned, he has no power whatsoever. So it would be really important for the WHO to put it amongst the measures that it's going to take, because it's not clear here. High-level advocacy in support of the ministers of health, advocacy to the heads of state, advocacy to the parliaments, advocacy to the ministers of finance. Why am I saying this? I say that for some of our projects, external intervention assists, for instance, with Gavi, or with the Global Fund when they come to the countries. Sometimes it's with co-funding, and they go to see the Minister of Finance, and sometimes that is what works. It is extremely helpful. Data is important. WHO should be a little more aggressive. No other agency is doing it. The World Bank is not doing it. Or at least we don't think so. The WHO should assist us in collaboration with these financing agencies to develop powerful tools to collect data, evidence-based data. Assist the countries to formulate plans that are intelligent and can govern the allocation of resources, and to evaluate these plans in terms of their efficiency. And finally, it is important for the WHO to facilitate or develop a partnership with the financing agencies like the World Bank and the IMF, because they influence the allocation of resources in the countries, especially the weakest countries. On this note, I would like to commend this agenda item and express the wish that our Secretariat will have a real action plan to support the region in general, and where necessary, each country in terms of these matters. Because we cannot have primary healthcare, we cannot have UHC if financing is not taken seriously. Thank you. Thank you. Guinea has the floor, will be followed by Angola.
Merci, Monsieur le
Thank you, Chairperson. The Republic of Guinea takes note of this document. I would like to congratulate the Secretariat for the quality and pertinence of the subject. The situation of financing in our countries is very critical. More than 60% of the burden of disease is on the shoulders of the sick person and the family, and very often it is by direct payment out of pocket expenses for care. And the share of health in the state budget is still very low. So the main reform with respect to financing that we conducted in our country to improve access to services and financing is the adoption of the National Primary Healthcare Strategy, which in our case consists in offering each community a package of 17 integrated activities, preventive, curative, promotion through the community health workers. This strategy will be funded by the Local Development Fund, financed from 15% of the mining revenue of the country. We hope that this measure, which will go hand in hand with the increase in the share of the budget in of health in the health sector in the state budget, will help to reduce the burden on the people through this direct funding. On this note, the Republic of Guinea supports the adoption of the measures proposed in this document. Thank you.
Je vous remercie.
Thank you. We give the floor to Angola, and Benin will follow.
Muito obrigado.
Thank you, Chairperson. I would also like to congratulate the WHO for presenting this important subject and say that in Angola, the approval of the National Development Plan for 2018 to 2022 and the budget of the state is providing a favorable environment for the reforms with a view to ensuring sustainable financing of health and thereby contribute to improve coverage of the services by protecting the populations from the catastrophic results of health-related expenditure. Some of the measures taken by the government include the fact that health is a priority for human development in the National Development Plan, and so the investment in the sector has increased as a percentage of the GDP. The percentage of health in the state budget has gone from 3.6% in 2017 to 4.3% in 2018, which made it possible to recruit more professionals. The exemption of medicines from tax duties and an increase in taxes on tobacco and alcohol. Ongoing reforms with a view to strengthening the regulation of pricing of medicines. At the moment, the National Survey on Family Expenditure and Income will make it possible to gradually reduce health expenditure with a view to ensuring universal health care. We agree with the measures proposed for member states, but we will need technical support for the definition or revision of the essential health package based on the socio-sanitary situation of the countries. The production of statistics and information will also be necessary for the universal health coverage. Angola, in partnership with the WHO and its partners, will continue to build capacity with a view to reducing the impact of health expenditure, and that way will continue to pursue the objectives of the SDG. Generally speaking, we support the document, but we hope that the recommendations presented by the partners and the measures proposed, if implemented, will help us to make progress with respect to sustainable financing for universal health coverage. Thank you, Chairperson. Thank you. Benin has the floor, to be followed by South Africa. Chairperson, the report of the Secretariat reflects the problem of our countries as well as the solutions that are being implemented under the leadership of our President. Every year the needs in the French health sector continue to increase, but the resources do not make it possible to increase the budgetary allocation. The commitment of this government is high to improve resources allocated to health, but the government is concerned by the quality of expenditure. And so our ambition is to improve the governance of resources allocated to the health sector and to improve our capacity in terms of accountability. So measures have been taken to ensure continued services to the populace by removing the right to strike for the health workers, for instance, and also to ensure that both the public and private sectors are taken care of. To enhance the credibility of the health sector in terms of management of its resources, we're working to ensure that most of the actors are transparent in the utilization of resources, even when it is insufficient. We tried performance-based funding, and the results were quite mixed, but we continue to think about how to provide our country with the possibility of improving its procurement mechanism. We are convinced that, as the report announces, technical support of the WHO will enable us to continue the in-depth reforms that we're carrying out now. We accept the report, and we hope that the support of the WHO will help us to improve the sustainable financing of the sector. Thank you. South Africa has the floor, to be followed by Cape Verde.
Thank you, Chairperson. We thank the Secretariat for the report. The implementation of universal health coverage does depend on sustainable financing. We acknowledge that we must ensure that domestic funding is secured, even in the context of a gloomy global economic environment. This is one of the questions that I get asked most frequently in my country. That is, will national health insurance, what will national health insurance cost the country, and whether the country will afford it? My answer to this question is always to ask it in reverse. Can our countries afford not to have universal health coverage? And the answer is a big no. My president made it clear last Friday at the stakeholder meeting on the National Health Insurance Bill when he said we must view the health budget as an investment and not a consumption. The central principle in universal health coverage is the pooling of funds. For South Africa, this means pooling the current health expenditure in the private and public sectors and put it together for the benefit of the whole population. It also means we must change the way we deliver services and ensure that we generate maximum efficiency. We note with appreciation that many countries, for example Japan, started to expand coverage during a slowdown in their economy. Similarly, the UK introduced national health system immediately after the end of the Second World War, when the economy was devastated by the war effort. In fact, most European countries which have got universal health coverage falls within this category. This strongly underlines the fact that universal health coverage is more of a political will than economic abundance. I am suggesting here directly that many of the countries implementing universal health coverage did so when their economies were not necessarily doing very well, but they were forced to do so to protect the health of their population, which usually gets accompanied by economic upturn with increasing wealth and increasing life expectancy. No economy can grow when its people are sick. Healthy people are productive people. This is the message that we must take to our heads of state. None other than the president of the World Bank, Dr. Jim Yong Kim, had the following to say about universal health coverage, and I open quotes. Universal health coverage is a smart investment. Healthier societies are more productive societies with stronger economies and more cohesive communities, close quotes. In addition to the support to member states offered by the WHO, it will be useful for the WHO to work with member states to quantify the return on investment for each of us if we fully implement universal health coverage. This may convince those who are still in doubt that indeed universal health coverage is a good buy. We welcome the offer by the World Health Organization and partners to support countries to ensure that we can motivate for sustainable funding of universal health coverage even within our own resources before we even go out to try and raise money outside our own countries. I thank you.
Thank you very much. I give the floor to Cape Verde, and I ask Ghana to get ready to take the floor after them. Thank you very much, Mr. Chairperson. First of all, I would like to congratulate the Secretariat for the presentation of this proposal for decision. In fact, I believe that in all our countries, we all face some problems between reconciling demand and supply in the health services sector. And it is true that the underfinancing of all our health systems does exist. Yesterday we had a very useful discussion not only on financing but on the issue of the inefficiency of budget execution. I believe that the issue of inefficiency also has to do with underfinancing when we have difficulties in sourcing human resources, in proper planning. This is obviously going to have an impact on efficiency and the execution of the budget. Countries face many problems with regard to how to budget for health and how to allocate more budget to health from domestic funding sources. However, I believe that we need to adopt a more holistic approach. and a multi-sectoral approach. I believe that it is possible, based on the Declaration of Helsinki, to mainstream health into all policies of all sectors. And whether it is the Ministry of Environment, the Ministry of Tourism, or other ministries that have got direct impact on the health of the populations, I believe that if we involve them, we will be able to improve health for everybody. But to agree with what was said by the Minister of Seychelles, I believe that the WHO and many other international organizations can have more relevant impact by ensuring more advocacy, so that specific international funds such as the Environmental Fund can channel more funds to health. I'm sure that they could also give more preferential treatment to the small insular developing states, because they also face many effects of climate change. In Cape Verde, we are carrying out various actions, but there's one specific aspect that we need to take into consideration that has to do with the protection of the population through a health insurance system or scheme. We are in Cape Verde increasing the mandatory health insurance, and 47% of our population is already covered by a state health insurance scheme. But the idea is that we should increase coverage in order to be able to offer more health insurance to more population. There's another important issue that will be discussed during our meeting, and that has to do with innovation in health. And I believe that it's important for us to adopt a clearer and more robust vision with regard to health technologies and how to ensure electronic governance and management of health information. I think that we could make very good use of such information and technologies. Thank you. Thank you very much. We give the floor to Ghana, and then Nigeria can take the floor after that.
Mr. Chairman, Ghana welcomes the opportunity to deliver this statement. Ghana joins all other delegations in expressing our sincere thanks to the Secretariat for bringing this very important topic for discussion. We in Ghana recognize health financing as the third part of the tripod in achieving universal health coverage, access, quality of care, and health financing sits at the heart of this tripod. In the past 15 years, Ghana has made substantial progress in a quest to attain universal health coverage. Active membership of our National Health Insurance Scheme has moved from about 1.3 million in 2005 to 11 million in 2018, representing about 40% of the population. The National Health Insurance Scheme is currently the financial backbone of our health delivery system and engages over 4,000 public and private healthcare providers. It's not surprising that Ghana is considered as an example of global good practice, and it's amongst a handful of only emerging countries in Africa to actively start implementing universal health coverage. Over the years, many countries in Africa and beyond continue to visit the National Health Insurance Scheme to understand its operation for possible replications in their respective countries. Recently, Ghana received a delegation from an East African country. Despite the progress made over the years, the scheme is confronted with sustainability challenges, which Ghana believes member states can learn from. Key among them, high utilization rate by members, fraud and abuse of the system by some credentialed service providers, resulting in high claims costs, premiums not actuarially determined, administrative and operational inefficiencies. Year on year, the scheme has also been confronted with funding gaps, leading to about 5% of claim payments running into arrears. To address the aforementioned sustainability challenges, the following measures have been implemented, and which is still ongoing. Review of our financing model to secure additional inflows. This is an area which we realized was very critical, especially in the area of mobilization. In most parts of Africa, we have a huge informal sector, which are not captured in our formal net. How do we rethink and recalibrate to get this large informal sector pool contributing fully into our schemes so as to raise more funds and also not to overburden the few who find themselves in formal sector employment, though easy to collect. Issues of operational efficiency, restructuring of the entire National Health Insurance Scheme, review of our National Health Insurance Benefit Package. We've recently conducted a burden of disease study, moving into the different arms of it and seeing how we recalibrate and create a benefit package that we can sustain within our fiscal space. Full automation of our claims processing to minimize fraud and abuse. Strengthening of our quality assurance and internal audit functions. Currently, we are looking at an amendment of our current law to make it a crime to violate any of the NHIS rules. We are also looking at obtaining prosecutorial powers from the Attorney General to prosecute service providers who abuse the scheme. This came out very handy because we realized that most often than not, people who abuse the scheme, it goes to court for a very long time. And sometimes the surcharge doesn't make it punitive enough for people not wanting to abuse the scheme. So since it's a high social agenda, we want to put very high above any abuse against the scheme. The penalty should be huge enough to serve as a deterrent to others in moving in that direction. Ghana strongly believes that any health insurance reform should be accompanied by a comprehensive health systems reform. It cannot be done in a siloed approach. We should look at this in a more of a broader approach. In this regard, our delegation strongly endorses the framework of action for strengthening health systems for universal health coverage and SDGs, which encourages innovative means to raise funds. We also welcome the move to get the Ministry of Finance to be part and parcel of this conversation. And we are even really thinking, how do we get the Ministry of Finance to lead the conversation? Instead of saying we are getting them on board, how do we get the Ministry of Finance to lead the conversation and help get on board? We welcome all the actions proposed by the team, and we want to endorse the report that has been stated so far. Thank you very much.
Thank you very much, and I give the floor to Nigeria, and Gambia can prepare to speak afterwards.
Okay. Mr. Chairperson, the Nigerian delegation wants to thank the Secretariat for introducing this agenda. We believe achieving universal health coverage will require sustainable financing for health, particularly primary health care, and abolishing user fees at the point of care. Nigerian government, specifically in establishing a mechanism for improving domestic financing for health, enacted the National Health Act 2014, which established the Basic Healthcare Provision Fund as an additional source of funding for the health sector, in addition to normal budgets. The Basic Healthcare Provision Fund is targeted at a minimum package of healthcare services at the primary healthcare level, with strategic purchasing of the services through the health insurance gateway. It's also meant to give 5% of the fund to public health emergencies. It is hoped that with the effective operationalization of this fund, out-of-pocket expenditure will be reduced and there will be efficiency and accountability in the health sector. In addition, we have also developed the National Health Financing Policy and Strategy and the Operations Manual for the Basic Healthcare Provision Fund, which will serve as frameworks for the operationalization. There's also the establishment, the production of the Universal Health Coverage Framework, which involved all sectors, because health is not only about health, but about other sectors. And this was championed, or this was supported by the WHO. So we are appreciative of the WHO in-country office for helping us develop the Universal Health Coverage Framework. Again, the National Health Policy 2016 and the National Strategic Care Development Plan 2018 to 2020, which is our 5-year strategic plan for health in Nigeria, also has its goal as achieving universal health coverage. The government has continuously strived to generate evidence for improved decision-making towards universal health coverage. And this we are doing in collaboration with WHO and other stakeholders. And we are helping states to establish their own health Financing Technical Working Group and desk officers to ensure that health will be appropriately financed using domestic resources. We have also trained the different health. We have also trained the desk officers on health financing at different states and also trained them on other financing options and methodologies with a focus on universal health coverage. We have also institutionalized the National Health Account Study, and currently we are doing the 2017 National Health Accounts. Finally, Nigeria has been trying to ensure that we perfect the use of the system of health account tool in carrying out National Health Account Study. And we hope with the states coming on board, we will be able to do well in trying to look at all the expenses in health and introduce efficiency in using the available resources for health. We have also been able to look into our national health insurance law, which for now is not mandatory. We are trying to make it mandatory, and is currently before the National Health Assembly. On the whole, we take note of the report of the Secretariat and support its adoption. Thank you.
Thank you. I give the floor to Gambia, and Senegal can speak afterwards.
The Chairperson, the Gambia appreciates the efforts of the Regional Director and team for this very important and timely document. As alluded to, government expenditure on health across the region is still below the 15% Abuja Declaration. This document presented charts the way for effective and efficient health financing mechanism towards the attainment of universal health coverage within the framework of the SDGs and in the Gambia in the context of our National Development Plan 2018 to 2021. Chairperson, the Gambia is currently working with development partners to improve the health care system to attain the SDGs and make health attainable. Currently, we are assessing the health sector through the support of the World Bank, USAID, the Global Funds, WHO, and the UN system to see where we could start from and come up with a very sound policy of health intervention. We continue to improve access and quality services with the aim of leaving no one behind. We call on the development partners to support the current transformation of our health sector in the Gambia, taking cognizance of our emergence from a dictatorship resulting in weakening of institutions and poor working conditions inherited, particularly within the health sector. The new Gambia is drawing from best practices to improve the financing of the health system, working closely with the Ministry of Finance as partners and taking lead to support this process. There is high political will from our President and Cabinet, but we need adequate financial and technical support to improve the health sector, given the context we are emerging from and the need to build the institution. This transformation is targeted at working towards sustainability and fulfilling the SDGs. To that effect, the Gambia supports the adoption of the said document for better health systems and services and outcomes in our region. I thank you for your kind attention. Thank you.
Je vous remercie.
Thank you. I give the floor to Senegal, and Liberia can speak after that.
Par ma voix, le Sénégal prend acte du rapport et félicite le secrétariat pour la qualité du document proposé. Nous remercions également le secrétariat pour avoir inscrit ce thème si important à l'ordre du jour de cette session. Le Sénégal a mis en place un système d'assurance maladie à base communautaire subventionné qui consiste à suivre.
En anglais ne marche pas, apparemment.
Sorry. Hello, can you hear? Yes. Senegal has implemented a health insurance for the community that is subsidized by the state in order to ensure universal health coverage. It is also ensuring that it can subsidize various health subsidies at 100% on 100% for the people that are suffering from mild diseases. Thus, 49.3% of the population are covered by one or other health insurance. And
cependant, le défi de la soutenabilité.
The challenge of sustainability of these measures in our country arises. For domestic financing, Senegal proposes other strategies for mobilizing resources. But one of the ways is through the diaspora, and that helps us to take care of the vulnerable populations. Senegal supports the measures proposed by this report. Thank you, Chairperson. Thank you. Liberia has the floor, to be followed by Comoros.
Thanks, Chair, for the recognition. Liberia takes note of the issues and challenges that are documented and expresses appreciation to the committee. Liberia is one of the countries that has made a significant progress in meeting the Abuja Declaration, yet the allotment to the health sector is not sufficient to meet the cost of running the sector due to the size of the budget. Therefore, an innovative thought process could guide us in making sure that no one is left behind in the attainment of universal health coverage. The government of Liberia has a pro-poor agenda. WHO, as our technical partner, needs to help us in finding a mechanism that will help us in meeting the major financial gap that has to be bridged through domestic funding. As been said repeatedly, health is not cheap, and therefore attaining universal health coverage has to be a bilateral agreement between the people and the government for ownership. Liberia is pleased with the efforts the committee has made in the proposed action that will serve as a roadmap to help us in navigating the complexity in the sustainable financing for universal health coverage. Mr. Chair, with the introduction of the Community Health Assistance Program in Liberia, we see an insight to access to health by all of our population. Yet, Liberia still has a problem in bridging the financial gap. Liberia takes note and will adopt the action proposed within its country context and endorses the adoption of the committee's report. Thank you.
Thank you very much. I'd like to give the floor to Comoros, and then Sao Tome and Principe can take the floor after that.
Nous avons des problèmes avec le micro de Madame le ministre des Comores.
We have problems with the microphone of the Honorable Minister of Comoros.
Merci, Monsieur.
Thank you, Chairperson. Chairperson, Comoros would like to congratulate the Secretariat for the quality of this document entitled Ensuring Sustainable Financing for Universal Health Coverage in Africa in the Midst of Changing Global and Local Economic Factors. Chairperson, universal health coverage is a key tool for ensuring the best quality of life possible and put in place, set on course, sustainable and inclusive development. My country, Comoros, has just since October 2017 introduced UHC by presidential decree. It is based on national solidarity through a compulsory health insurance system which guarantees access to all on the basis of real quality health services. Chairperson, Comoros, after considering the content of the report entitled Assuring Sustainable Financing for Universal Health Coverage in Africa in the Midst of Changing Global and Local Economic Factors, adopts the measures proposed and wishes to make the following recommendations to Member States: to build on all financial mechanisms for universal health coverage through health mutuals, performance-based funding, private insurance, etc., to benefit from expertise in place, to be mobilized in favor of compulsory health insurance, and to use evidence-based mechanisms such as health observation of human resources, and mechanisms or dialogue where dialogue or advocacy platforms exist to share experiences in terms of strategies for setting up health insurance, and more specifically in terms of the management structure for the compulsory health insurance. To the WHO to support member states in their strategies to strengthen their health systems by giving priority to public policies and development of public health facilities, particularly community-based health facilities and primary health centers, to support member states in the process of identifying the indigent populations who should benefit from subsidies from member states, to support member countries in the strategic approach to households in the informal sector, to support member states by supporting the constitution of platforms for expertise for universal health coverage and compulsory health insurance. Thank you.
Je vous remercie.
Thank you. Sao Tome and Principe has the floor, to be followed by Gabon.
Obrigado.
Thank you very much, Mr. Chairperson. Sao Tome and Principe would like to thank the Secretariat for having brought this item to us for discussion. The challenges are many for our government, but we have been making efforts to improve health care. We have implemented various mechanisms to mobilize funds that can be affected to the health sector. We've increased taxes on alcoholic beverages and tobacco, and with the extensive support of the WHO, we were able to create health accounts from 2012 to 2014, and at this specific moment in time, we are reconciling our 2015-2016 health accounts. Telemedicine has been implemented with our partners, and we were able to give more resources to our health system. So Sao Tome would like to support the recommendations contained in this report as a way of ensuring the sustainability and financial sustainability of universal health care. Thank you. Thank you very much. We give the floor to Gabon, and then Zimbabwe can speak after that. Thank you very much, Mr. Chairperson. Gabon would like to thank the Secretariat for the quality of the document that has been provided, which contains the challenges that we face in terms of universal health care, especially due to our financing situation and challenges. Gabon would like to say that it is important for us to ensure health through the creation of health insurance. We've also carried out our health accounts, and after 10 years of existence, 100% of Gabonese civil servants are covered by health insurance. They are the first ones to benefit from this health insurance, and today we have health insurance that also covers 6% of the private sector. So these private health sectors already have about 70% of membership from private sector. The decision to create a universal health care insurance system has benefited our population, and it is viable. There is still a part of the population that is not eligible, and these are workers in the informal sector and religious leaders. But the situation of Gabon is quite difficult, but the health insurance system now does include people that are neither in the private sector or in the informal sector. We have got new challenges, and therefore Gabon has to find new sources of financing, especially for the more vulnerable portions of the population. This requires the Ministry of Health to reorientate its focus points, focusing therefore on preventive health, which constitutes a large part of our interventions as well. The reconciliation of our more recent health accounts indicates that NCDs create as many expenses for the health system as communicable diseases. Gabon is therefore at a crossroads with regard to the NCDs and the CD situation. And we believe that NCDs are going to create more and more expenditure for the health sector, and therefore our health insurances will need to cover these NCDs unless we want our families to pay catastrophic health expenses, which I believe is not the case. Therefore, at the moment, Gabon is involved in ensuring these health insurances in order to ensure better quality care to the population, and all of this in order to attain UHC. Our financing mechanism is a mechanism that provides financing based on outcomes and not inputs. And so it's important for us to be efficient and to ensure economies of scale. Mr. Chairperson and dear delegates, today we cannot speak about financing of health or the attainment of UHC if our countries, our member states, are not able to commit and carry out their commitments in the Abuja Declaration, which is to affect 15% of the general state budget to health. So we need to encourage member states to continue to financing health, and this bearing in mind the many challenges that face our African continent. Gabon does support the proposals made in this document, and we believe that it's important to more specifically take into consideration the need to reconcile the national health accounts as an instrument to help us make decisions in the area of health in the future. Thank you very much. We give the floor to Zimbabwe, and then Congo after that.
Merci, President. I would like Zimbabwe really appreciates the report by the Secretariat, and we are in total support of the actions required thereof. I want to point out, Mr. Chairman, that I like the paper because in the background, right in the first paragraph, it makes it very clear and in very simple language what universal health coverage is. And this is really very important for selling universal health coverage to our colleagues in Cabinet, and also for the populations to understand what is universal health coverage. And I've been attending a lot of these committees, regional committees, and it is very rewarding to listening to colleagues when they make their contributions, because you learn quite a lot from that. We have, as Zimbabwe, we've had a positive experience in the area of universal health coverage. In the area of universal health coverage, and we have had various delegations visit us to share our experiences. Firstly, as far back as 1999, we set up a National AIDS Trust Fund, which we call the AIDS Levy, where we tax 3% of anybody who is employed, and we put that into the National AIDS Trust Fund. and it's an AIDS levy that is resourced. It's completely resourced from our domestic people. It makes significant contributions to our fight against HIV. We have had prepaid health insurance in the country since the early 1980s. This is really called medical aid. This was largely covering those employed formally or supported by those employed formally. Due to the economic challenges in the country, we've gone through this. This has covered only 10% of our population. And currently, we are trying to address this anomaly, and we are trying to adopt a regulation that encourages the informal sector to be covered by such insurance through innovatively crafted packages. We, as a government, have set up a health levy based on 5% tax on mobile airtime and data usage. So what we are doing, Mr. Chairman, is we encourage our people to use their cell phones, their cellular phones, because we know, as the Minister of Health, will be getting 5%. We'll be getting 5 cents out of every dollar that they phone. So people are phoning, and we raise close to $4 million every month from this. And we've used this to provide blood free of charge in our hospitals, and also those on dialysis machines are now getting that service free. And we are also using that levy to make our medicines a bit more available to our public health institutions. Our health services takes the primary health care approach, and we are strengthening this approach by further decentralizing from the rural health centers to creating village health posts, which offer a suitable package of services supported by higher levels of care in the system. With the ministry responsible for social welfare, we are just about to finalize the very important national health insurance, whose objective is to provide cover, particularly for the indigent citizen. We are now generating evidence from institutionalized national health accounts, as well as the national aid spending assessments, and this has made us much more confident in justifying resource requirements from Treasury. We are confident that these and other approaches to financing healthcare will help us move towards transitioning from global and bilateral financing support to a largely domestic-based resourcing of our move towards effective universal health coverage. Again, Mr. Chairman, we support the recommended actions, and we urge all of us to work on these. I thank you, Chair.
Je vous remercie.
Thank you. Congo has the floor, to be followed by Lesotho.
Merci, Monsieur.
Thank you, Chairperson. The Republic of Congo would like to thank and congratulate the WHO for the quality of the document presented and the in-depth analysis deriving from it. Beyond the measures proposed for member states, we commend and support the measures proposed in paragraphs 21 to 24 and call for their immediate implementation and the establishment of a monitoring mechanism. In the Republic of Congo, we have increased our health sector budget to 13% on the average for the next 4 years in the framework of the 2018-2022 National Development Plan, especially for the medium-term budget for the same period. For 2018, the share of the budget is 11.26%. To mobilize the funds, Congo organizes policy dialogues regularly with the other components of government and partners and parliamentarians in order to advocate for internal resource mobilization. This resulted in the necessary budgetary allocation to finance the major health expenditure. The Republic of Congo supports the health insurance project in support of the UHC, and this was contained in the project of the President and is being implemented by the line minister. Congo has taken a series of legal of laws to ensure universal health care. However, the country has not yet succeeded in having universal health insurance because of some lapses in the technical and regulatory apparatus for the process. Congo is therefore happy with the WHO's proposal to support countries, which will help to speed up the process in our country. With regard to financing for health, like other countries of the region, Congo continues to have concerns with regard to mobilizing sustainable funds. The national health accounts show that there is inequity with respect to the allocation of the funds, and there is very little efficiency and effectiveness of expenditure. In the country, countries pay 34% of the expenditure in terms of out-of-pocket expenditure. So efforts need to be made to have prepayment mechanisms. Congo has just come up with a national health development plan for 2018 to 2022, and in it the strategic orientations to attain the SDGs in due course have been defined. Now the country has to effect the necessary reforms in order to ensure the necessary sustainable funding for health. These reforms have already been embarked upon by the country. The reactions of delegates have been generally in the area of the action that has to be taken towards the ministries of health, of finance, and the parliaments for external funding. In some cases, such as Congo, they were used to finance some of the expenditure that the states could not take on board, especially those relating to health promotion and technical assistance. So there has been complementarity between external funding and state funding. With regard to support for the introduction of sustainable funding for UHC, the WHO is encouraged to work hand in hand with financial institutions such as the IMF and the World Bank, as well as regional and sub-regional financial institutions such as ECOWAS, ADB, CEMAC, etc., to ensure the establishment and operationalization of the funds for universal health care. These institutions have the advantage of working with states in managing public finances and in adopting mechanisms to facilitate the execution of budgets, bearing in mind the specificity of some health expenditure. All the work we're doing will only be effective if we ministers of finance have the same understanding, align the work with our priorities. Thank you. Thank you. We give the floor to Lesotho, the last speaker.
Thank you. The Kingdom of Lesotho wishes to first congratulate the Secretariat for a well-written report and the recommendations outlined. It is a well-known fact that ensuring sustainable financing is a critical element of attaining universal health coverage, and therefore contributing to the Sustainable Development Goals, the SDGs. However, the critical challenge is access to financial resource for attainment of the universal health coverage in our region. The current coalition government of the Kingdom of Lesotho's main priority is universal health coverage for all citizens of Lesotho, regardless of their geographical location and their economic status. The goal is set despite the unavailability of national health insurance scheme that will ensure sustainable financing. In the current national budget, health has been allocated around 12.4%, which is slightly lower than the 15% Abuja target. Primary health care service in government and child facilities in Lesotho have no direct cost to individual clients and patients as the government is taking over. However, due to difficult terrain to reach some facilities, particularly in rural areas, indirect costs are incurred in areas of transport, both to and from the facility, and this often creates inaccessibility to essential health service package. The said scenarios therefore leads to high rate of impoverishment due to ill health. As such, the Kingdom of Lesotho highly appreciate recommendation in the report and wish to highlight that as the first and critical step, the country has embarked on establishing additional clinics and health posts to the rural community to ensure equitable access to essential service by all and leaving no one behind. We believe that the strategy will enormously reduce out-of-pocket spending for majority of the rural population. Furthermore, improving access to essential health service will improve disease prevention, timely diagnosis and treatment, which will further reduce disease burden at secondary and tertiary level facility, which, as opposed to primary care service, are in Lesotho at a subsidized cost to patients. Moving forward in ensuring sustainable financing, the Kingdom of Lesotho has embarked on the following: mobilizing for increased budget allocation for the Ministry of Health by the central government, ensuring efficient use of allocated budget through priority setting and strengthening monitoring and supervision at lower level, better coordinate partner resources to ensure alignment with national priority through resource mapping, mobilizing the local companies for domestic financing of healthcare. I thank you, Chair.
Je vous remercie.
Thank you. Mauritania has the floor.
Merci, Monsieur le Président.
Thank you, Chairperson. Thank you, Secretariat, for preparing this excellent document. I'm taking the floor to make a case for our actions for access to health services in our strategic plan. The ministry intends to encourage all actors to subscribe to the health insurance system, and we would like the WHO to encourage these actors to do so, because our country has a its own geographical specificity, and we have problems of access, geographically speaking. In addition, the informal sector accounts for a large part of our activities. Thank you, Chairperson.
Merci.
Thank you, Honorable Minister. Following all these comments, does the Secretariat have something to add?
I would like to, on behalf of the Secretariat, thank the interest and the feedback from 31 of the member countries. We take note especially of the progress that has been made by the different countries in various forms in terms of increasing the budget allocation, in institutionalizing processes like national health accounts, in establishing innovative ways of increasing resources for health through various taxes and levies. There's a lot that has gone around that could be a lesson to many other countries. We also appreciate the progress being made towards establishment of prepayment schemes and health insurance schemes. But we also take note specifically for the call to improve and enhance the issue of governance and accountability in how these resources are collected and used and applied. We also take note of the call to have a more invigorated action in involving the politicians, so to have high-level advocacy for heads of state, the ministers of finance, and parliamentarians. But we also take note of the fact that it's not only the finances that have been called upon, but we also need to look at changing ways in how to provide the services, and this was brought out very well. So that it's not only the money, but what we actually provide and purchase. And I think strategic purchasing was one of the calls that we needed to look at. We also take note of the need to have a multi-sectoral approach so that we can get the opportunity to have gains from health through other sectors and through their policies. And also the call for WHO to work hand in hand with financial institutions, as has been stipulated. Let me first of all also give you an insight into the work that WHO has been doing in this particular area. We've been supporting countries, more than 36 of them, for example, have been supported to develop their health information strategies and policies. And we're also supporting the operationalization of building the capacity for health insurance schemes, public finance management, and financial.
Mike Socio.
And I think the system is not yet. Is it? It's okay. Okay. So, and I said the last point I was talking about was the fact that WHO is supporting countries in operationalizing a number of areas, specifically for building capacity towards health insurance schemes and prepayments. It's not on? You can hear? Is it okay? Okay. Is the translation okay?
Yes, it is. Yes, it is. The interpreters can hear you. Please continue.
And the financial protection. We've also supported countries for costing their plans and projections for expenditure in terms of how do they meet the universal health coverage targets. And also helped in looking at issues of fiscal space analysis to determine feasibility of the various options for financing. We've supported, of course, the national health accounts, and we are glad that a good number of countries already have started institutionalizing their national health accounts. We've also gone ahead to support dialogue with other and advocacy with other ministries, especially with the Ministry of Finance. We had the Ministers of Finance and Ministers of Health conference in Tunis through UNECA. And we have also been working on partnerships and finance scorecard for the heads of state. So we hope that these would be helpful in working on this. We have also been engaging with the regional economic communities in the East African Commission and WAHO. Let me also take the fact that the opportunity to respond also to, I think, in particular here, since I'm talking about support for WHO, the issues that were raised by Central African Republic. We need to note that we, as WHO, have been also supporting Central African Republic for their national health account study, and also through the courses for financing for Francophone countries. But it's our conviction that we need to have tailored country support to address the issues of the particular country in question, and we'll work on that as part of our regular enterprise. I may want to look at a few specific things. I think there was a call from Kenya for focusing on using examples in the document, using more examples of the countries in the region, and will sharpen the document accordingly on that. We also critically highlight the critical role for Ministry of Health and Legislature more clearly, and also look around how to improve in the document the enabling environment for the private sector. Tanzania also talked about the issues of contextualizing the actions to country context. Indeed, yes, that will have to be done by country. But also they called for support for manufacturing of vaccines and drugs in the context of self-reliance in order to have the prices down. And there's going to be a paper on access to vaccines and drugs also that is coming later today. There was an issue from Seychelles about the seeds concerns, and I think that's very important to look at, where there are many drivers for increasing the costs, especially the burden of disease now moving to NCDs, and therefore calling for higher spending, and therefore calling for better resource mobilization, but also the issue of looking at other issues like human resource, where this causes a lot of expenditure for the sector. So we'll look at that, but in terms of the comprehensive human resource development agenda across the African region. There are also issues on data. I think that if we are to do all this very well, we need to have data, first of all, to provide evidence, but also to help us monitor how well we are doing in terms of improving financing, but also improving access to the quality of healthcare that we need. There was also DRC brought out the issue of the high dependence on external funding, and I think that's one of the things we do mention in the paper. This has to be done, and the focus really is how do we increase domestic funding vis-a-vis the external funding for sustainability's sake. There were issues that I think were brought up which are very important in terms of having in place appropriate systems for collecting and administering the revenue and ensuring that there is efficiency that is attached to the resources that are raised. I think several countries have brought the issue of saying that UHC is really not just a technical issue, it's a political issue. Therefore, the engagement with the politicians at the highest level possible in this is very important, as well as using the legislature that eventually decides on the allocation of these funds. Cape Verde brought out the issue of use of innovations, especially technology that's coming. I think this is very important. Use of technology could help us reduce the costs and increase the coverage of services in the country. So that is another very important aspect, I think, to consider. Ghana raised the issue of, and among others, raised the issue of the huge informal sector. And I think when we look at national health insurance schemes and the preparedness schemes, we need to very much look at how do we enable the informal sector to benefit from funding. Yeah, basically, I think those were the major key ones that I thought I should respond to. And I thank you very much for all your inputs and feedback, which we will take into consideration. Thank you very much.
Thank you very much. Dr. Tumisini, and now I give the floor to the Regional Director. Thank you very much, Mr. Chairperson. Good morning, dear ministers and heads of delegations and partners. I would first of all like to thank you for the interest that you have shown in this subject, as well as the encouragement that you have given us regarding the work that we have done to support you in the area of health financing and funding.
Starting by the last one, that UHC is a political issue. I think it is indeed a very political issue, and we are observing, if you look globally, some of the debates going on in many countries, including many high-income countries, about universal health coverage, with really, if you like, political positioning and sometimes ideology driving the positions and the strategies adopted in countries. So I think it's a matter of choice. Often it's a matter of political strategies by countries, and we need to understand, and I'm happy that it's understood in that way, that it's not only a technical matter for us, but it's also something that we need to pursue at the political level. That is why during all my visits to countries and the meetings and audiences that I have with heads of state, with parliamentarians, with ministers of finance, we make the advocacy for financing for health and for the appropriate strategies for financing for health. So we've understood that very well. We've also asked several heads of states to champion this issue at the continental and global level. The president of Ghana, for example, who is a strong advocate for domestic funding and for transitioning beyond aid, has been asked to champion this at the level of the African Union. We had an audience yesterday with the president of Senegal and asked him to champion the cause of universal health coverage in the political space with his peers, and we are planning with the Director General, working through some member states, to propose that we have a side event at the African Union Summit in order to remind heads of states about the importance of financing for health within the context of financing for development more broadly. So this is something we are doing in addition to the work that we spoke about yesterday at the side event on public finance management. We are doing with ministers of finance. finance to try to help collectively that we make the case, the investment case for health, and be more capable of engaging in the dialogue with them for better financing for health. So I'd like to thank for that observation and agree very strongly that this is something that we need to work on in many dimensions. I'd also like to make a comment on how to access financing for other sectors, including money that's available for climate change, for the environmental interventions, which is important for health. We are actually working with member states to understand mechanisms such as the Green Climate Funds and the Global Environmental Facility. Several years ago, we worked with countries to help to situate the health sector better in some of these mechanisms. We've developed some tools, and in our partnership with the environmental sector, we have worked with countries to see how the health sector can also make a pitch for some of this money successfully. Just to say again, this is one of the matters that we'll be discussing at the ministerial meeting that we will be convening in Gabon with the support of the Gabon government with ministers of environment. So this partnership is essential for us to better access other funds that are targeting other sectors for the benefit of health. Just in response, my colleague already made reference to it, to how WHO can be more present and how we can have more capacity for supporting in a consistent way the work on financing for health and more broadly universal health coverage. This is something on which we are working as the Secretariat. There's been a dynamic movement in the last couple of years, including a discussion at the G20, a discussion at the meeting between Japan and African countries a couple of years ago to recognize universal health coverage. We need to see this translate into financing for UHC at the international level, including for the work that WHO has to do and has to have the capacity to support you consistently. We have, I think, in possibly 20 countries, experts who are the focal points in each of the country offices on universal health coverage and health system strengthening, some of whom are health financing experts. We clearly need to expand our capacity for this. I'd like to appeal to member states in your dialogue with partners to make the case to have capacity to help you in health systems areas, including in financing for WHO and other relevant partners. One of the ways we are going to achieve this, as we referred to yesterday, is through the review of the type of staffing that we have in the countries. And as I said, it's emerging more and more strongly that we need more staffing in the health systems area, more staff, including financing for health, more staffing in helping to improve the availability of data in countries. So I'd like to advocate that this is something that we do together in order to make the case for capacities, specifically expertise for health systems work, so that we can take this agenda forward. But I really would like to thank honorable ministers for your strongly expressed interest in embarking on this work, and say that we are committed to supporting you to make progress in it. Thank you very much.
Thank you very much, the Regional Director. And from now, we would like to give the floor to the Director General of the WHO to say a few words.
Thank you, my brother and chair. And I would like to start actually by thanking His Excellency President Macky Sall for the great honor he bestowed on me. That was really a great honor, and I'm really grateful, and thank you so much. Merci beaucoup in a big way. Maybe something associated with the award is Lion in Africa. It has a special prominence. So thank you so much for your confidence in me. Of course, this recognition, since I'm just starting as DG, this recognition is actually a reminder that I should do more. And that's how I understood it. Then going to the issues that you have raised, I'm really happy and was listening carefully that I'm happy that we have almost the same position. And I think we have to now channel this energy into one, and as CD said, this is a political issue, it's a political choice, and it needs a commitment at the highest level possible. Our heads of states, heads of government, finance ministers, foreign ministers, and other officials should also help you. This cannot be done by the ministries of health. If it's a political choice, then as you rightly said, there should be a political commitment at the highest level possible. And what I observed today, the energy I observed today, is really great, and we have to channel it. So the proposal I have, in addition to what Dr. Moeti said, we have already agreed, the regional office and the headquarters, to host a meeting on the margins of the AU summit. And one small recommendation I would like to make is for the bureau chaired by the chair, the Minister of Health, Abdoulaye Diop of Senegal, and also the vice chairs as a bureau to work with us. So if possible, instead of a side event, it could be an agenda, since we still have time, an agenda in the plenary, in the main document itself. So we can push for that. And we have now a good number of sponsors. And Minister Aaron was telling us yesterday, which I know, and by the way, the commitment of Minister Aaron is really great. And he has already secured the commitment of his President Ramaphosa, and he has openly announced his commitment, and he is also willing to champion. That's what he said when we met him. And then we have the President of Rwanda, His Excellency Paul Kagame, who is the current AU African Union chair, who has a commitment. Of course, if I go on, I will list more and more heads of states and heads of government who really committed to this. But we're just bringing this as few examples. And the President of Senegal also assured us yesterday. But there is a list already, and there is readiness. There is now that commitment. We can see it, and that's why what you're saying. So we need to really channel it, and that's why we have to do something at the AU summit now. It's better to hit while the iron is hot, and we can see that the iron is already hot, and we have to hit it hard. And January will be a good opportunity. And I'm asking for the leadership of Minister Abdoulaye Diop and his colleagues, the vice ministers. And from my side and Dr. Moeti's side, we're ready, and to make the next AU summit as really successful as possible, and to have a great and clear commitment by our heads of states. During that session, two things we can achieve. One, renewed commitment on universal health coverage, that's collectively as Africa. And the second is commitment to domestic resource mobilization. That's to increase domestic resources. One example I can give you on this is, in running the African Union, the heads of states and governments of Africa took it seriously, and I remember under the leadership of His Excellency the President of Paul Kagame, they decided to cover 100% of the recurrent budget of African Union, 75% of the program budget, and 25% of the peace and security. And I know they have been discussing, when I was acting as foreign minister, on how they can mobilize resources to achieve these goals. And there is already interest from our leaders to increase domestic resources. And this is another opportunity that we can use because they're already doing it for some other things. So this could be included as part of that exercise which they're already doing, and by now I think they must have gone a long way. So universal health coverage, political commitment, and then primary health care as a foundation, which we have already stressed, and then increase on domestic resources to make it happen, because at the end of the day, the most important financing and the most sustainable is actually domestic resources. Anything that comes from outside is always a complement or a supplement. And that's the position that you're already saying. And we have already heard many good best practices from countries, and we don't need to reinvent the wheel. We can pull together those best practices, and we can have better mechanisms of tapping resources from our countries or domestic resources. So thank you so much again, and I hope our chair, Minister Abdullah Diop, will comment on this. I'm asking officially to lead us on this as chair of the regional committee, and the bureau is his vice ministers, and we would be happy, myself and Dr. Moeti, to do everything to use the opportunity to make sure that what you're asking is done together. Thank you again. Thank you, Your Excellency.
Je vous remercie, Monsieur le Directeur Général. Je crois que...
Thank you, DG. You were very clear in terms of the guidelines you gave us, and the mandate of the RC is extremely clear also in terms of the AU summit. Following the comments and observations as well as reactions of the Secretariat and the interventions by the regional director and then the Director General, shall we take it that the regional committee is ready to adopt actions proposed in document AFR/R668/10 entitled Ensuring Sustainable Financing for Universal Health Coverage in Africa in the midst of changing global and local economic factors, taking into account the comments made? It is so decided. The proposed actions are adopted.
Nous allons donc passer la...
We shall now give the floor to some observers who wish to make statements on this agenda item. First, the World Health Federation, and I want to invite their representative to take the floor, present their statement.
Est-ce qu'elle est là?
Is the representative of the World Health Foundation here?
Honorable Chair, distinguished delegates, the World Heart Federation thanks the WHO Afro Secretariat for its comprehensive overview of the challenges facing member states in the region. We support its proposed actions to strengthen health financing, to accelerate progress towards universal health coverage, and commend those countries that have already made progress in this area. As the report notes, health authorities must engage more productively with ministries of finance to promote action on UHC, and as civil society representatives, we pledge to do more to support ministries of health to make this case, and to emphasize the economic and social benefits UHC can bring. These benefits can be achieved through action to prevent non-communicable diseases, which represent an increasing proportion of deaths in the African region. This is especially true of cardiovascular disease, with the regional prevalence of adult hypertension the highest in the world at over 40%. Consequently, countries cannot make progress towards universal health coverage without tackling their national non-communicable disease burdens, in addition to the coexisting communicable disease burden. Recent research demonstrates that health expenditure on NCDs is indeed an investment, not a cost. The Lancet Task Force on NCDs and Economics estimates that investing just $1.5 more per person per year in the SDG era in the 20 countries with the highest NCD burden would avert 15 million deaths, 8 million incidents of ischemic heart disease, and 13 million incidents of stroke. The same paper notes that investments in prevention and control of NCDs offers a high return for countries at all income levels. We therefore strongly support the report's recommendation to countries to tax unhealthy commodities such as tobacco and alcohol, as included among the WHO best buys, and we urge countries to embrace this recommendation. The evidence is irrefutable. These fiscal measures can lead to both public health benefits and provide the revenue to accelerate scale-up of universal health coverage. Thank you for your attention.
Thank you, representative of the World Health Federation. Next, I'll pass the floor to the representative of the Union for International Cancer Control. Thank you, Chairperson. We would like to thank you for giving us the opportunity to make this statement on behalf of the UICC. This is an organization that represents 162 organizations working on cancer in the Africa region, and we are very happy about the proactive work done by the WHO Afro in preparing this comprehensive report on financing universal health coverage, considering that funding is a major obstacle to progress in all WHO regions. This report reflects clearly the challenges facing the region and raises a number of issues and actions that are difficult to achieve if we are to reduce the impact of the high cost of health on individuals, families, and communities. To facilitate progress with UHC, we wish to urge member states to give thought to the following recommendations. Once, to ensure the inclusion of cancer in all the services of the UHC, the charge of NCC, including cancer, increased by 30% over the last 10 years, mainly because of the prolonged nature of treatment of different cancers. This disease is a major cause of catastrophic expenditure. Consequently, the essential package of UHC should include measures to care for cancer and other NCDs so that everybody has access to quality essential services without undergoing heavy expenditure. Use national cancer control and NCD control services to put in place the essential packages. And thirdly, ensure equity in the planning of UHC. This report recognizes the difficulties relating to inequitable expenditure on health. So we wish to urge member states to come up with long-term financing strategies that will enhance equity and enable countries benefit from all the advantages of the universal health coverage. We commend the pooling of risks through measures such as prepayment systems and insurance systems, and encourage states that have put such measures in place to share their experiences so as to facilitate implementation at regional level. UICC congratulates members of the Africa region for the work done. We are ready to assist countries to reduce the burden of cancer. Thank you, Chairperson. Thank you. Now I give the floor to the International Federation of Pharmaceutical Manufacturers and Associations. Thank you, Chairperson.
Opportunity to contribute to this important discussion today. The IFPMA represents leading research-based pharmaceutical companies as well as national and regional industry associations across the world, including 3 in Africa. The IFPMA notes the report and agrees with the proposed action, specifically with recommendation to increase domestic public funding for health, shift out-of-pocket payment to more progressive means, and establishing up-to-date packages of essential health services. IFPMA believes that structured, collaborative action on universal health coverage will help meet the shared goal of expanding patient access to medicines through innovative solutions and achieving long-term sustainability of the health sector. Meaningful progress and sustainable solutions can only be found in multi-stakeholders approach, and we call for recognition of the value that the healthcare and pharmaceutical industry brings. The pharmaceutical industry is an important partner, especially in regards to investing in medicines and vaccines development and pursuing innovative approaches to expand access. In addition, working in novel partnership with NGOs, governments, and private sector entities, the industry is supporting UHC through providing expertise in ensuring the quality and integrity of the supply chain, training healthcare workers, and filling gaps in underserved areas. These all support capabilities which are becoming increasingly essential as the burden of NCDs rises in Africa. Populations age and more countries transition to middle-income status, demanding improved healthcare services. Access to negligible tropical disease intervention are also an integral part of UHC, particularly in Africa. And here the private sector also played a crucial role through commitments such as the London Declaration. We are a natural solution partner to government and patients. Given the complexities associated with UHC, we encourage government to explore working through public-private partnerships focused on a wide range of areas, from health literacy and health system strengthening to access to quality service and financial protection schemes. We believe that UHC will only be achieved after a process of learning from experiences and evolving innovation. Such processes will produce the best healthcare models tailored to the need of each country, instead of a one-size-fits-all solution that potentially limit growth. A strong health economy based on country self-sustaining model consistent with national economic development goals is essential to ensure a sustainable system, independent from development assistance. We stand ready to work hand in hand with government to support new models of health financing and delivery that are adaptable to local conditions. Thank you, Mr. Chair.
Je vous remercie.
Thank you. I would like to thank all those who have taken the floor. I was consulting to see whether we shouldn't take the lunch break after item 11 and drop the coffee break because we're running late now. So if this is acceptable to you, then Dr. Pascal Mkanda should take the floor so that we can go on to item 11 of the agenda. Is he here? He's not here? He's here.
Le comité régional accepte certainement qu'il ne dit rien consent.
Well, obviously the regional committee has accepted because silence means consent. So we go on to item 11 of the agenda entitled Framework for Certification of Polio Eradication in the African Region. Please refer to document AFR/R668/8. And so I'll give the floor to Dr. Pascal Mkanda to introduce this document.
Yes.
Il y a une spécialiste, non?
Oui.
On peut y aller. Merci, il y a une spécialiste qui va nous aider à...
Thank you. Well, our expert is going to let us move a little, help us move a little.
You hold it first, you hold it first.
here, please. We need a bit of a stretch to get the oxygen going. Some air in you. Right, can we start up? Stretch. I want you off your feet, on your tiptoes. Right, we are going right. 1, 2, 1, 2, 1, 2. We are going go. Side. Right, twist. Up. On your tiptoes, please. On your toes. Thank you.
Je vous remercie.
Thank you for that workout.
Pour la présentation.
So now Dr. Pascal Gada has the floor to present the report.
Yeah? Yeah. Okay. All right. Okay. Thanks. All right. Thank you very much, Mr. Chairperson, honorable ministers, distinguished guests. Before I introduce the framework for certification or polio eradication in the African region, I would like to introduce Professor Rose Leke, who is here at the invitation of the regional director. Professor Rose Leke is the chairperson of the African Region Certification Commission, which is responsible for certifying the region polio-free. Professor Rose Leke. Okay. Yes, that's right. Okay. So, Chairperson, honorable ministers, and distinguished guests, on behalf of the Secretariat, I have a privilege to introduce the document AFR/RC 68/8 entitled Framework for Certification or Polio Eradication in the African Region. And this is a very important document. The purpose of the document is to propose to member states priority interventions towards certification or polio eradication in the African region and to remain polio-free post-certification. As we are all aware, and including during the remarks made by the regional director on Monday, the African region has made marked progress towards poliomyelitis eradication. By August 2018, no wild poliovirus case has been confirmed in the African region for 2 years. If this progress is maintained, the African region could be certified to have eradicated polio-free by end 2019 or early 2020. However, as we discussed in the previous regional committee side meeting in Zimbabwe, there are still some challenges really to certify this region to have eradicated polio. And as I said in the introduction, before I needed to propose the interventions to be done for us to be certified polio-free, since we have the chairperson of the certification commission here, I will really give a few minutes for her to really tell us some of those concerns which they have so that we can see how best we can address those. So with your permission, Chairperson, I'd like to hand over for a few minutes to Professor Rose Leke to say some few words.
Thank you. Okay, thanks. Sit. Thank you.
Chairperson, honorable ministers, and distinguished guests. First of all, I'd like to extend my gratitude to the regional director for inviting me to present here today on behalf of the African Regional Certification Commission. In 1988, the 41st World Health Assembly did adopt a resolution to eradicate poliomyelitis globally by the year 2000. And all member states that were represented by their ministries of health committed to this eradication of poliovirus, the wild poliovirus. Partners then of the polio eradication initiative, that is WHO, CDC, UNICEF, Rotary, and then the Bill and Melinda Gates Foundation, have together with governments and countries and civil society and so on, have been working together to achieve this goal. The African region continues to make progress towards certification, as the latest wild poliovirus case was confirmed 2 years ago. This progress is acknowledged with caution, as some localized areas in member states remain unreached due to insecurity. However, let me re-emphasize that WHO region is considered for certification only when all member states demonstrate the absence of wild poliovirus transmission for at least 3 consecutive years in the presence of certification standard surveillance. The African Regional Certification Commission, which I chair, is an independent body appointed by the WHO Regional Director for Africa since 1998 to oversee certification and containment processes in the African region. It currently comprises 16 experts in public health, pediatrics, neurology, virology, immunology, and is the only body that's entrusted by WHO to certify the African region to have eradicated polio. The ARCC reviews and provides feedback on country annual certification reports and complete national documentation, country surveillance and preparedness response plans to polio outbreaks, reviews country polio laboratory containment activities, and country polio assessments. The ARCC also undertakes polio eradication verification field visits in countries before the presentation of file and documentation, and it conducts high-level advocacy for polio activities. We visit countries to strengthen the capacity of the national polio certification committees. At the moment, the ARCC has accepted national documentation of polio-free status from 40 countries. And a plan exists between now and 2019 to review the national documentation of the remaining 7 countries. Tentatively, the region could be certified to have eradicated polio by the end of 2019 or 2020. However, the Commission has concerns in certifying the African region to have eradicated polio due to continued surveillance and routine immunization gaps, including some blind spots due to insecurity. Also, the Commission has observed that surveillance and routine immunization performance has declined in some member states once their national documentation has been accepted by the ARCC. This is a worrying development, and these countries risk the accepted documentation of polio-free status revoked and invited to present again the national documentation before certifying the region to have eradicated polio. To sustain the momentum towards certification, we will continue to undertake selected advocacy missions and use every opportunity like this ARCC, to advocate to ministers of health to quickly close the observed gaps. I'd like to urge all member states in the region to meet the set criteria for certification in a timely manner by quickly closing the surveillance and population immunity gaps. The framework for certification of poliomyelitis eradication in the African region articulates the strategies that have to be implemented by all countries to meet the set criteria. Chairman and honorable ministers, let me use this opportunity to remind ourselves of the declaration by our heads of state during the 25th ordinary session of the African Union in Johannesburg, South Africa in June 2015, whereby polio eradication was declared our historical legacy to future generations. Let me end by thanking the Regional Director, Dr. Moeti, for the advocacy mission she has undertaken to heads of states and ministers of health in response to our requests, and for our continued personal commitment to polio eradication in the African region. Honorable ministers, we all have a real chance now to be part of a once-in-a-lifetime public health history. Let us do everything to make this happen. I thank you very much.
All right, Mr. Chairperson and honorable ministers, based on the concerns which the chairperson of the RCC has articulated, the framework for certification of polio eradication in the African region proposes to member states priority interventions towards certification of polio eradication in the region and to remain polio-free post-certification. The key areas in the document focus on strengthening surveillance, accessing children in secure areas, containment, improving preparedness for polio outbreaks, strengthening routine immunization, and sustaining the gains within the context of polio ramp down and transitional planning. The 68th session original committee is now invited to take note of the framework, review, and endorse it for action. Thank you very much, Mr. Chairperson.
Je vous remercie.
Thank you, Doctor, and I thank the chairperson of the ARCC. Now I would like to invite the distinguished delegates if they have any comments on this document.
Oui, nous donnons la parole au Niger d'abord.
Niger has the floor. Thank you, Chairperson. In the framework of polio eradication, efforts made in the area of routine immunization, implementation of several mass immunization campaigns, strengthening of surveillance, and social mobilization have yielded a lot of results. In Niger, the last case of WPV was 2012 and vaccine derived in 2013. The country was declared polio-free in 2016. From January 2016 to April 2018, all the 16 rounds of mass immunization covered the areas of interest, that is the Maradi region, as well as Zander and Difa regions. Chairperson, these results would not have been achieved without the precious and constant support of the WHO and other partners. This is why I would like to seize this opportunity to sincerely thank the WHO and all other partners who have supported us. Niger continues, in concert with sister countries of the Lake Chad Basin, the implementation of the response plan for the outbreak in the Lake Chad Basin area. Recently, the country analyzed the risk of transmission following the notification of cases of vaccine-derived poliovirus in the Lake Chad Basin, and this showed that the risk is still high. Chairperson, the challenges and gaps, the major ones are characterized by the present presence of hard-to-reach areas for immunization and surveillance, nomadic and massive movement of people across the borders as a result of insecurity, as well as various socio-economic reasons. The difficult access of the Niger islands of the Lake Chad region and other difficult to reach areas in Tawa and Tillaberi. Consequently, Niger, alongside neighboring countries, continues to carry out some strategies which include strengthening surveillance activities, targeting refugee camps and camps of IDPs and the nomad camps, exchange of information between the border districts of neighboring countries, as well as periodic cross-border meetings, intensification of communications activities, capacity building for laboratories, and implementation of special activities in markets and nomad camps. Chairperson, in conclusion, while expressing our desire to see the WHO support these interventions earlier mentioned, I wish to mention that we support the measures proposed in this document, because if they are implemented, we will see the eradication of the certification of polio eradication in the region. Thank you. Thank you. Zambia has the floor, followed by Chad.
Chairperson, Zambia is honored to take the floor and wishes to thank the Secretariat for their work in making available the report on this agenda item. As a country, we are pleased to report that as of June 25, 2018, IPV was introduced in the routine immunization schedule over 2 years after the switch from trivalent to bivalent oral polio vaccine. We have noted with concern the continued outbreaks of circulating vaccine-derived polio virus in neighboring and regional countries. An indication, as noted in the report, could be due to incomplete withdrawal of trivalent OPV, and urge all countries to prioritize this. We are, however, mindful of the fact that some of these had mutations traced to pre-trivalent OPV withdrawal time and have persisted. Chairperson, while we appreciate the targets set in the framework, we feel the milestones should have included some of the key objectives of the polio eradication and Endgame Strategic Plan 2013 to 2018, such as the time frame by which it is hoped that all member states shall introduce IPV, and containment of all potential poliovirus infectious materials, rather than leaving it open for individual member states. This becomes important seeing that some member states are already behind in achieving the set objectives of the endgame strategy. We need to reset our objectives in line with the targets of the framework, against which we will objectively measure our successes towards achieving certification of polio eradication in our region. With these proposals, Zambia is happy to support the adoption of the framework. I thank you.
Je vous remercie.
Thank you. Chad has the floor. I will be followed by Ghana. Thank you, Chairperson. I would also like to add my voice to the colleagues of Niger, to strongly support the implementation of this framework for the certification of polio eradication in our region. Like Niger, also in Chad, we had our last case in 2011, and at the time, a large delegation from the Bill and Melinda Gates Foundation came, and Mr. Gates himself came, and the authorities were invited to commit strongly to ensure that Chad becomes polio-free. At the time, what was decided was to declare war on poliomyelitis. In our zone, in the Lake Chad region, it is really war against polio that should be declared, because the difficulty there is that it is a zone of insecurity, and it is also made up of islands. The last 3 campaigns that we carried out in the Lake Chad Basin area required us to use the army to gain access to some of the islands, and therefore to thousands of children who were not getting any health care otherwise. So, in order for us to achieve this objective, because for 2 years now we have not had a case. The last case was on 21st August 2016 in Nigeria. We are only 1 year away, and we hope that this year all the partners can pool their efforts so that we can really be done with polio, especially in the Lake Chad zone, where we need to deploy different strategies or involve all the communities so that each child can be vaccinated. I believe that this is what we want to claim, to make a case for. And the second one, equally important, is surveillance. We need to strengthen surveillance in our countries. Not only for the country to be polio-free, but also for us to be able to maintain that status, because that is the more difficult part. The third, and not the least, is to move on to the next stage of routine immunization. Every day we should be able to vaccinate the children. A lot of means have been put into polio, and now we need to avail ourselves of this means, of these strategies, of the people who have been trained to ensure that we vaccinate more of our children. These are my few observations in support of the strategies, so that more resources can be made available to finalize with this framework for certification. Thank you. Thank you. Ghana has the floor and will be followed by Mozambique.
Thank you, Mr. Chairman. Ghana is grateful for this opportunity to deliver this statement on the framework for certification of polio eradication in the African region. Mr. Chairman, Africa, indeed the entire global community, have made much progress towards global polio eradication initiatives. For 24 months consecutively, we have not recorded any wild polio case in the African sub-region, which has to be sustained. Consequently, the African region is of the firm belief of being satisfied of having eradicated polio by 2019 or by early 2020. While remaining cognizant of this possibility, we need to constantly remind ourselves that certification of polio eradication is conducted on a WHO regional basis, and a region is considered for certification only when all member states demonstrate the absence of wild polio virus transmission for at least 3 consecutive years. In this regard, Mr. Chairman, Africa is one unit, and we need mechanisms to support and complement individual country efforts and work together as a united front. It is equally essential that we as states in the African region harmonize our efforts at this moment of polio end game. Despite the progress made, we currently have gaps in polio surveillance among some member states. Regrettably, this development poses a major threat for the region in fulfilling the criteria for certification of poliomyelitis eradication by the end 2019. Mr. Chairman, all member states in the region successfully withdrew the type 2 component of the oral polio vaccine by May 2016 and switched from trivalent to bivalent OPV. As of June 2018, 39 of member states, representing 79%, have introduced IPV in their routine immunization programs, with the remaining 10 member states failing to do so due to global shortage. The routine immunization coverage in the region has stagnated at around 74% for a number of years, and having recorded outbreaks of circulating vaccine-derived polio virus confirms indication of low population immunity against polio. The risk of re-emergence of wild polio in countries that have claimed polio-free status still exists. We need to work on this at a fast pace to prevent the unfortunate circumstance of backsliding in our efforts and losing the gains so far made. All member states in the region need to monitor themselves critically on all the important indicators and milestones and provide the needed attention and support for the last push to send polio out of the continent forever. Mr. Chairman, Ghana shares the view and supports the framework proposed by WHO for member states regarding priority interventions towards certification of polio eradication in the region and to remain polio-free post-certification. We need to work together as a region to address issues and challenges of insecurity and inaccessibility that result in pockets of low immunization coverages, low population immunity, reducing support for polio-funded activities, and persistent surveillance gaps. This, by far, is the surest way to achieve our vision of a region free of polio virus and to fulfill our goal to achieve certification of the region as polio-free by the end of 2019. Thank you, Mr. Chairman.
Thank you very much. We give the floor to Mozambique, followed by Kenya afterwards. Thank you very much, Mr. Chairperson. I would like to start by congratulating the Secretariat for introducing this topic in this session, and I'd like to reiterate Mozambique's commitment to the eradication of polio. In 2015, Mozambique was declared polio-free. There was evidence that we no longer had the wild polio virus in circulation in the country. However, in 2017, there were sporadic cases of wild polio virus, as well as circulating vaccine-derived poliovirus in the Zambezi province. We introduced the polio vaccine in 4 doses, and we've carried out various efforts to maintain immunization above 90% of coverage. We are applying all notification standards in terms of acute flaccid paralysis throughout all the districts of the country, and we would like to believe that with all these efforts that we have been carrying out in Mozambique, we will be able to contribute effectively to the eradication of polio in Mozambique. Having said this, I would like to thank you, and I'd once again like to reiterate our congratulations for the presentation of this topic. Thank you. Thank you. I'd like to give the floor to Kenya, followed by Nigeria.
Yeah, thank you, Mr. Chairman. The Kenya delegation would like to thank the Secretariat for preparing this framework for certification of polio eradication in the African region. And we strongly believe that the framework will guide our member states in implementing key polio eradication initiatives as we negotiate the last lap in the long journey of a global polio eradication initiative which started way back in 1988. Kenya takes note of the priority actions proposed in the document, which include, among others, conducting risk assessment, strengthening surveillance, and with expanded use of technological innovations, improving preparedness and the quality of polio outbreak responses, reaching children in insecure areas, laboratory containment of poliovirus, strengthening national certification committees, and also implementing the international health regulations of 2005 and strengthening routine immunization. Mr. Chairman, it's encouraging to note that the African region has not reported any wild poliovirus in the last many years, and that if this situation is maintained in the coming months, the region should be certified polio-free by the end of 2019 or early 2020. Sadly, though, we note that the continued isolation of vaccine-derived polioviruses from both environmental samples and human cases is a potential major setback to the realization of this important milestone. And as Kenya, we therefore call for concerted efforts by all of us to improve the quality of our immunization as well as the AFP surveillance systems. Mr. Chairman, Kenya reaffirms its commitment to the fight against polio and implementation of polio eradication activities in accordance with the resolution of WHA 68.3 adopted during the 68th World Health Assembly. We reported the last indigenous wild poliovirus in 1984. However, the country has had 4 importations since then that have resulted in a total of 36 wild polio cases. More recently, a circulating vaccine-derived poliovirus type 2 was isolated in one of the samples collected from an environmental site in Nairobi. And following this isolation, Mr. Chairman, we have conducted 3 successful rounds of vaccination campaigns in high-risk counties using monovalent OPV2. Further to this, and following the isolation of circulating polio type 3 in Somalia, we will be launching on the 14th of September 2018 a synchronized polio campaign within the Horn of Africa through the initiative of IGAD in order to stem these circulating viruses. Mr. Chairman, in line with the resolution WHA 68.3, Kenya has also successfully implemented a number of polio eradication initiatives, including the introduction of IPV in November 2015, and we've done this into the routine immunization. We have continued to enhance our environmental surveillance that we established following the polio outbreak in 2013, and currently we do have 9 collection sites in parts of the country, and plans are underway to increase this surveillance site to 18 by the end of 2018. We've also implemented the switch from trivalent to bivalent on 18th of April 2016, and the process was successfully validated by a National Polio Certification Committee. And Kenya is also on course to implementing the laboratory containment of polioviruses. Mr. Chairman, in order to address the low immunization coverage recorded in the recent past, the government, in collaboration with other stakeholders, have been investing heavily in various strategies, including routine immunization services, to ensure that all children get the life-saving vaccines. And we are happy to note that recently, His Excellency the President of the Republic of Kenya launched a program for equipment in order to further strengthen the primary health component towards attaining universal health coverage. The President also launched an aggressive 100-day rapid results initiatives in the entire country aimed at ensuring that we reach the approximately 500,000 unimmunized children. And the pace at which these interventions are implemented, however, are being hindered by several challenges, including insecurity in the northern and the northeastern parts of the country, inaccessibility of vaccination services in some hard-to-reach areas, as well as inadequate funding for acute flaccid paralysis surveillance activities. With that said, Mr. Chairman, Kenya would like to take note of this report and commits itself to fully support the proposed actions in the framework. I thank you, Mr. Chairman.
Thank you very much, and I give the floor to Nigeria, and Angola will follow.
Mr. Chairman, thank you. Mr. Chairman, Nigeria appreciates the opportunity to intervene on this topical agenda item. It is pertinent to stress that the plans to eradicate polio are well on track. For 25 months now, we've not had a case of the most virulent strain, as the wild polio virus in Nigeria, and this buttresses the fact, even though we are having some polio viruses being detected from environmental sites in some of our states. for which we have mounted a robust response jointly with our development partners. The environmental component is key to the polio eradication initiative, and therefore we are not resting on our paddles towards stopping the transmission of all forms of polio viruses in Nigeria. The fact that we have been able to stop the circulation of the wild polio virus for over 2 years now is a significant achievement. The last wild polio virus case was reported in August 2016 from the insurgency-ravaged state of Borno in the northeast zone of the country. We have since been able to achieve this through effective collaboration with security agencies in this zone by adopting the following strategies that will expand and guarantee polio vaccination in areas that are inaccessible to vaccinators due to insecurity in Borno and other parts of the northeast zone of the country. These strategies are the Reaching Every Settlement Initiative, RES, done with the Civilian Joint Task Force and military escorts, and the Reaching Inaccessible Children, the RIC, intervention done with only the military through training of their officers on administration of vaccines. Through these strategies, we have been able to vaccinate close to 500,000 children in this area where we have the security challenges. And this we started in early 2017. We are also collaborating very effectively with the Lake Chad Basin countries to mitigate the risk of transmission across those borders. We have established a Lake Chad working group jointly with our partners, led by a very senior government official based in Borno, to fast-track the implementation of the Lake Chad Basin Country Action Plan for polio eradication. And we're working together with the Lake Chad Basin Polio Eradication Initiative Task Team in N'Djamena, Republic of Chad. We're also making concerted efforts towards strengthening our routine immunization. At this point, we however require some clarification from the chair of the certification committee on the criteria for certification. We are getting some conflicting information. We're told that certification can only be effected if we have 3 years of absence of the wild polio virus in addition to 18 months without circulating vaccine-derived polio virus. So we would like some clarification on this. Mr. Chairman, Nigeria is fully committed to the provisions of the Regional Framework for Action on Polio Eradication and Certification. While thanking the Secretariat for the good report, Nigeria supports adoption of the proposed framework and will abide by all its provisions. Thank you, Mr. Chairman.
Thank you very much. We'll give the floor to Angola, and the Central African Republic will follow. Mr. Chairperson, we would like to thank you for the opportunity that is given to Angola to speak at this important assembly, and I would like to congratulate the Secretariat for the excellent presentation regarding this topic. With regard and considering all the efforts and investments that have been made by all of us, we believe that the eradication of polio continues to be a high priority in terms of public health management. We believe that during this phase, there's an urgent need to accelerate the implementation and certification of the containment of the polio virus. The well-managed and successful containment of the polio virus will ensure that we have sustainability of polio eradication. On behalf of Angola, I would like to invite all member states to unite in order to renew our commitment to the eradication of the polio virus through the whole implementation of all strategies that have been defined in the strategy for polio eradication, including the introduction of the inactivated polio vaccine. And secondly, the to intensify efforts to accelerate progress of certification of containment of the polio virus. Mr. Chairperson, Angola has registered progress in this area, especially with regard to increasing equipment, improvement of immunization systems, strengthening of epidemiological surveillance and preventable disease. We would like to use this opportunity to thank all the donors, partners and member states for their commitment and for all the contributions that have been made to date, which have allowed us to make the achievements that we have managed to date. I'd also like to thank you for the continuous support that will be given to us until we manage to fully eradicate polio. Thank you very much. I give the floor to the Central African Republic, and Gambia will follow.
Thank you very much, Chair. We'd like to congratulate the Secretariat for the quality and pertinence of this framework proposed. The challenges identified therein and the strategies that are contained in the document reflect the current context and the needs of the Central African Republic. It's a difficult context, this background we work against, but I'd like to reassure you that we are determined to deal with this challenge and eradicate the disease. Under the initiatives underway, we have strengthened our actions in order to respond to all the indicators that were identified. For the last 3 years, we haven't had wild polio virus cases, and most of the indicators are being respected. However, we have a vaccination coverage percentage that is still not as high as we would like to, and we have security zones in the hinterland and also on the border. Our actions focus on 3 axes. On the one hand, we have to contemplate the security zones. We have a program of collaboration with the securities and also the armed forces that we've begun to meet with. We are aware of the fact that most of the armed groups can actually cooperate to facilitate vaccination of children in particular. We also have to strengthen routine vaccination. We are aware that there's too much complacency that has begun to set in, and we need to reinforce leadership to make sure that this vaccination is done. And we've created a task force, a high-level task force, including the Minister, WHO and UNICEF representatives. It's a key partnership that will help us establish this routine vaccination. This strategy, we believe, will meet this need. We would also like here to thank our WHO partners, Gavi as well, who have done everything they can to help us with the resources required. They have a lot of understanding and flexibility to help us in our context, against our background, deal with the indicators we have before us. Thank you for your attention. Thank you. I now give the floor to Gambia and then Ethiopia.
Thank you very much, Mr. Chairperson. The Gambia would like to comment on this very important and timely document on the framework for certification of polio eradication in the African region. Disability related to polio is a great burden to individuals, families, and communities. Yet polio is preventable using cost-effective immunization services. The Gambia commends the Secretariat for bringing this important topic for consideration by this body. The Gambia has been polio-free since 2004, attained largely because of our near universal immunization coverage over the years, using the primary health care system in which EPI services has since 1983 been an integral part of the reproductive and child health services provided at based clinics and outreach stations on a weekly basis, free of charge to the population. Importantly, in our efforts to maintain a polio-free country, the Gambia has been able to participate in regional synchronized national immunization days towards polio eradication held over the years within the ECOWAS region. Thus, the Gambia commends the Lake Chad countries for the initiatives towards polio eradication. To enhance our polio eradication efforts, the African region surveillance mechanism is essential. Therefore, the Gambia strongly recommends the strengthening of the surveillance within and among countries, to which WHO is critical. We urge that national polio committees be active to ensure the quality of annual updates and reports to maintain the momentum we hold. The strengthening of the I thank you for your kind assistance and to express our appreciation to our partners, particularly Gavi, that has been very instrumental in the recent effort in the Gambia in maintaining the success we have gained. I thank you for listening. Thank you.
Je vous remercie, Madame. Nous donnons la parole à...
Thank you very much. I'll now give the floor to Ethiopia and then Tanzania.
Thank you, Chair. Dear Chairperson, the Federal Democratic Republic of Ethiopia strongly agree with the statement presented. Ethiopia recognizes the progress made in limiting wild poliovirus transmission as indicated in the framework. It's important to highlight that Ethiopia has maintained polio-free status as accepted and approved by African Regional Certification Commission since June 2017. The government of Ethiopia is recognized the risk of occurrence of vaccine-derived poliovirus or importation of wild poliovirus if the world is not polio-free. We updated the National Outbreak Preparedness and Response Plan considering the situation in the Horn of Africa countries. We will continue to use all our efforts for the realization of the world free of any polio event so that all individuals and communities enjoy lives free from risk of polio disease. We would like to request the Secretariat to continue the support endemic and non-endemic high-risk countries to strengthen surveillance, immunization, and capacity to respond to polio event when it occurs. In this regard, the country urges the Secretariat to work toward this immediate implementation of this framework. I thank you.
Je vous remercie. La Tanzanie.
Thank you very much. I now give the floor to Tanzania and then Comor.
Thank you, Mr. Chairperson. The Tanzanian delegation commends the Secretariat of the Regional Committee for Africa for bringing this important agenda. We acknowledge the progress made in the African region for having a period of 22 months without any confirmed case of polio, and that this reflects on our joint efforts towards polio eradication. Tanzania is committed to implementing the activities recommended in the Global Polio Eradication and Endgame Strategic Plan. Routine immunization is being strengthened, especially in low-performing and hard-to-reach areas, using Reach Every Child approach. The country has maintained the population immunity by having a third dose of bivalent oral polio vaccine coverage of 97% at national level. In April 2016, we switched from the use of trivalent oral polio vaccine to a bivalent oral polio vaccine in the routine immunization. The introduction of IPV before the switch was not possible due to global shortage of IPV vaccine. This has since been introduced in April 2018. Mr. Chairperson, Tanzania has been polio-free since July 1996, with good quality surveillance and routine immunization services. The country was later declared polio-free status in November 2015 by the African Regional Certification Commission, and has sustained the two core AFP surveillance indicators at national level for the past 7 years, maintained administrative national routine immunization coverage of OPV3 over 90% for the last 6 years as well. We neither have polioviruses nor potentially infectious materials in our laboratories, Mr. Chairperson. Polio risk assessment has been conducted and submitted quarterly. National Stop Transmission of Polio team has been deployed to risk areas to strengthen active surveillance since 2012. A total of 14 national stop transmission of polio missions have been conducted. The country has been using Open Data Kit since 2018 for surveillance and supportive supervision. Mr. Chairperson, we took note of the actions proposed in the framework and we support the adoption. We thank you.
Thank you very much. I now give the floor to the Comores, and then Côte d'Ivoire follows.
Merci.
Thank you very much, Chair. Chair, I'd like to commend the 47 member states of WHO Africa for the efforts in combating polio. Chair, allow me to begin also by congratulating the Secretariat for the quality of the report presented to us, with the framework for certification of polio eradication in the African region being under consideration. Chair, honourable delegates, we had the approval of our documentation for Comores by the Certification Committee. In 2015, we were considered a country free of polio. Chair, the different bodies responsible for eradicating polio in Comores, including the National Committee for Certification, the CNEP, the committee responsible for confirming this, are up and running and regularly present an annual report to the regional committee. Since 2015, Chair, the country has introduced the inactivated polio vaccine in the country, and it has been used since 2016 in routine immunization of children. Our country has a response plan also for epidemics. Of course, surveillance is not always easy for us, but our surveillance system allows us to maintain the indicators that we have above 80%. Comores, Chair, asks WHO to continue supporting the country so that we can obtain polio certification in up to 2019. Last year, and also at the beginning of this year, with the WHO regional office, we listed our laboratories and their equipment. We support the measures provided for under this framework to eradicate polio in the African continent. Thank you, Chair.
Merci. Nous donnons la parole.
Thank you. I'd now like to give the floor to Côte d'Ivoire, and then we will have South Africa. I then believe we need to take a break, and we will proceed after lunch. Côte d'Ivoire, we have the floor. Thank you, sir. Côte d'Ivoire is dedicated to implementing this framework for certification of polio eradication and has undertaken a number of measures to implement WHO guidelines as well as other guidelines. We do not want circulation of wild polio virus, and we interrupted that in 2011, and we've also strengthened epidemiological surveillance. So the certification of our documentation is something we're also looking into, making sure that we have the measures that allow us to detect wild polio virus. Of course, we also need to make sure that the laboratories can help us detect this virus correctly. We have a strategic plan for 2013-2018 for the eradication of polio to strengthen the routine vaccination with the oral vaccine and the introduction of a vaccine in routine immunization since 2015. We also need to strengthen surveillance. We have surveillance agents on the ground, in priority areas in our communities. We've also improved the system that allows for the collection and transportation of the samples, and we also have environmental surveillance for this virus. These actions have allowed us to have the country declared as a country free of polio in 2015. The routine immunization vaccination is now in place. We have made great progress since 2011. Nonetheless, we have challenges still ahead. This includes higher coverage of above 90%. We want a network to look at circulating vaccine-derived polioviruses. We need to have community-based and outreach programs at community level to also continue monitoring wild poliovirus. Côte d'Ivoire congratulates the WHO for all the initiatives undertaken to eradicate polio, and we believe that we need to continue implementing this regional strategy to eradicate polio, and we support the document presented by the Regional Committee. Thank you, Chair.
Parole à l'Afrique du Sud.
South Africa has the floor.
Thank you, Chairperson. We welcome the report by the Secretariat on the framework for certification of polio eradication and note the progress made in the region. We acknowledge the need for all countries to be fully prepared and certify polio-free by early 2020. Equally important is to ensure that once the status is attained, it is maintained at that level. South Africa has been certified polio-free, but unfortunately we did take our eyes off the ball, and we need to strengthen our surveillance system ahead of the visit by the certification committee later this year. The lesson for all of us is that being certified polio-free can sometimes result in complacency if we don't maintain our vigilance all the time, and we cannot afford that. We wish to know that given that migration across our borders for both documented and undocumented migrants in many of our countries is a reality, we need to ensure that we have high levels of vaccination as well as vigilance in border areas and amongst the migrant populations. South Africa will ensure that we are fully prepared for the certification process, and that will maintain our polio-free status, and hence we support the document. Thank you very much.
Je vous remercie. Nous donnons la parole au Botswana.
Thank you, Mr. Chairman. Botswana continues to support the World Health Assembly resolution of interruption of wild poliovirus transmission by implementing priority interventions towards certification of polio eradication. Botswana has met the certification criteria in 2005 and continues to strengthen surveillance for acute flaccid paralysis in an effort to maintain the status. Botswana, like many other countries, introduced one dose of inactivated polio vaccine in 2015 as per the polio eradication and endgame strategic plan 2013 to 2018. And we wish to note the emphasis made by the chair of the certification committee this morning that for us to maintain the status, it's important that the entire region is certified. Botswana also recently adopted the 2017 revised reaching every district or RED guidelines. The strategy is aimed at strengthening immunization programs and address common obstacles to increasing national immunization coverage, which have been declining in the past 3 years. Other activities to improve the routine immunization coverage include celebration of the African Vaccination Week and the Child Health Days to accelerate implementation of the high-impact interventions. Botswana knows the report of the Secretariat on the framework for certification of polio eradication and the African region, and urges the WHO to ensure that polio assets, lessons learned, and knowledge acquired are used to support other national health priorities. For instance, in Botswana, as we forge ahead to eradicate malaria in the country. Thank you very much.
Je vous remercie. Donc, après le Botswana.
Thank you very much. After Botswana, we will have to leave the rest of requests for the floor. We have 8 for after the break. Madagascar, Lesotho, Uganda, Gabon, Benin, Sierra Leone, Guinea-Bissau, and Burundi. We also have Rotary International, who has asked for the floor after them. Zimbabwe too, I believe, now too. Would the Secretariat also like to make any administrative announcement before the break? Yes? Eniko over there?
Madam Eniko.
Madam Toth, would you like to make any announcements before the break? Yes?
Announcements to make. The first is that there is a lunch side event which is called Launch of the State of Health Analysis in the African region, which is taking place from 1 to 2:15 p.m. And the second side event, it's in room BC12, so just the side event room, the usual side event room. BC12. The other announcement is for Gavi. Gavi ministers are requested or are invited to meet in the coffee break today at 4 to 4:30 in the side event room BC12. You will receive invitations. Thank you very much.
Je vous remercie.
Thank you very much. We will now break and come back after lunch at 2:30 p.m. Thank you.